evening everyone. Today my poster presentation is on topic Rosai-Dorfman disease, that is beyond the lymph node, the spectrum of Rosai-Dorfman disease. So first of all, regarding its name, Rosai-Dorfman disease is based on the name of two pathologists, that is Joan Rosai and Ronald Dorfman, which were two pathologists working in USA, and they designed the name for this disease. So first of all, introduction. Rosai-Dorfman disease is a rare, usually self-limiting disease caused by histiocytic proliferation of unknown etiology in lymph node sinuses and extranodal tissues. It was previously described as sinus histiocytosis with massive lymph adenopathy. You know, the disease is derived from the overproduction of monocytes, macrophages, which leads to accumulation in the affected tissues. It usually presents with massive lymphadenopathy but can also involve extranodal tissues such as skin, liver, spleen and CNS, and can also mimic a lymphoproliferative disorder. Although in its classical form, it usually presents as massive bilateral cervical lymphadenopathy. It is frequently multifocal and evaluation of other areas must be considered. The involved gastrointestinal tract in RDD is the least common extranodal involvements. So case report, an 18-year-old female presented to the medicine department of GGSMCH Faridkot with a 6-month history of fever, cough, lymphadenopathy, abdominal distension and generalized body ache with no past history of tuberculosis. Past medical history and drug history, they were insignificant. General physical examination revealed average billet, mild pallor along with generalized lymphadenopathy and cutaneous hyperpigmented plaques. All lymph nodes were non-tender and they were firm in consistency. On abdominal palpation, there is massive splenomegaly along with there is a hepatomegaly present. A provisional diagnosis of generalized lymphadenopathy, query lymph proliferative disorder was kept and patient was admitted for further evaluation. So in a routine investigations, pancytopenia was there, peripheral smear show anemia and raised ESR was there. Chest X-ray was done and it showed clear lung fields and ultrasound was also done, which revealed hepatosplenomegaly with lymphadenopathy. And then the FNAC was done. With FNAC was taken from cervical lymph nodes and it showed lymphoid cells with scattered histiocytes with focal and peripoiesis suggestive of Rosai-Dorfman disease. Patient was put on steroids and the lymph node size started decreasing and the patient improved. Next is discussion. So Rosai-Dorfman disease is a rare, self-limiting disease with unknown etiology. It has two forms, classical form in which cervical lymph nodes are involved and extranodal form in which any other body organ can be involved. Most common extranodal site is skin and other organs like our brain, our other lymph nodes of axillary area, inguinal area, it can also be involved. And although any age group can be involved, but 80% cases manifest within the first 2 decades of life, because in young patients there are more viral triggers, there are more autoimmune diseases, so that's why it is more common in the first 2 decades of life. Classically, it presents with bilateral, painless, massive lymph nodes. Extranodal manifestation can be seen in 40 to 45% patients as involvement of skin, subcutaneous tissue, orbit, breast, bone marrow and abdomen. FNAC has important role in diagnosis of RDD. Differential diagnosis can be any lymphomas, disseminated TB, Langerhans cell histiocytosis, malignant histiocytosis, or any viral infection like HIV, Epstein-Barr virus, etc. So conclusion, it must be considered as differential diagnosis in patient who presents with bilateral or generalized lymphadenopathy with multi-system complaints, as the disease can present with various characteristics and it is a close mimicker of lymphoproliferative diseases. Thank you.